Hi everyone, this is Megan Matos with St. Ange Company, welcoming you to this week's episode of Taking the Supply Chain Pulse, where we chat with leaders from all areas of healthcare to discuss the issues of today's threats, challenges, emerging trends, and advancing technologies. We're joined today by Ted Rogalski, the administrator of Mercy One Genesis Aledo Medical Center and DeWitt Hospital. His vast experience in the healthcare industry has landed him a spot for today's episode. So let's kick back, relax, and get started with your host, the one and only Fred Kranz.
I've known Ted for 25 years. I think Ted may have been my boss for a day and a half. As when I came to Genesis Medical Center, I think Ted was the acting supply chain leader. So at least on paper, he was my boss for a while, and I learned everything I don't know from him. So that's good. Fortunately for Ted, he learned nothing from me. And because of that, he's gone on to have a great career. Ted, thanks for joining us. Happy to have you here.
Yeah, glad to be with you today, Fred.
Well, the reason I wanted to talk with Ted has got an interesting history in the sense that he has been in a private community hospital, a small to medium IDN, has run a couple of critical access hospitals, and along the way, that medium-sized IDN was involved in a merger and acquisition from Trinity Health in Livonia, Michigan, one of the nation's largest IDNs. So Ted has a unique experiential background. Let's go back to that time when you succeeded Afshin Fatolahi at Genesis as a supply chain leader. You were a young guy. How much did you know about supply chain before you took over the role? And what was it like to be in charge of that when you got jumped into multi-hospital campus and the whole deal?
Yeah, great question, Fred. Very interesting story on that. From an operational standpoint, I knew materials because that's how I started in healthcare. When I was finishing my undergrad and just looking for a job to get me through, I joined a predecessor organization to Genesis. At the time, it was called St. Luke's Hospital. And working in supplies, processing, and distribution. SPD is what it was called back then. So, that was kind of, the whole central supply storeroom, as well as all of the instruments for the OR, so sterile supply, and really had the opportunity to understand the operational piece of material services. And then after I moved on from St. Luke's, I went to the Twin Cities and worked in a large hospital there called Abbott Northwestern Hospital. And it was a promotion up into multiple areas that, materials covered. But it wasn't a department. It was actually a department of the OR in that organization. But it was all the components. It was SPD and sterile processing, all of those. So, long answer to your question, I did have some aspect of it. Probably where I did not have good knowledge is just on the whole purchasing side. How do we negotiate and bring in all of the supplies that our organization uses? And Afshin had built a great team. And that was early, in, I guess, the history of materials that really started getting sophisticated in working with physicians and really doing what we call value analysis and assessing not only the quality of what we're bringing in, but the price. And that was just getting started at that time. So, the one thing that I loved about the job was the negotiation piece. Really liked that because I was business major by background before I got into healthcare. So, that really drew me into that role.
Yeah, that's interesting. And one thing that Afshin did, and I had done it places I had been before, was Afshin brought in clinicians into the supply chain. It wasn't even called supply chain. It was still materials management. Exactly. He brought in clinicians into materials management to work with the clinicians at the point of use to understand what they did and how to best contract to meet their needs. Is that something that you learned that you've taken with you along the way?
Yes, absolutely. And in fact, I think, Fred, that was a great learning opportunity for me. And especially when you look back at the start of that our relationships were completely separate, if you will. All the physicians were independent, none of them were employed. So you really had to build a strong, tight relationship and kind of, get them at the table to say, hey, here's why it's best to advocate for, the hospital and the system as it relates to getting supplies in the organization. We can reinvest in, high technology to help support you providing the best care.
After supply chain, you went into imaging, and so it's interesting to me because I started out myself. My first director position was director of sterile processing and distribution. Okay, we call it central processing and distribution at Baptist. Same thing. And I had like 7 years counting the military of being a caregiver before I had one day's experience as a manager. And by the time I got to be a manager, I learned how things worked. And it sounds to me like, the fact that you went back into imaging, by the time you got to be an administrator, you'd had a similar experience of understanding how things worked within a medical center. What was that like when you graduated to become an interim hospital leader?
No, I would totally agree with you on that, Fred. I think it's something that set me apart early in my career in that I had that practical operational experience. Now, I'm not a clinician, right? So I was always kind of on the business side of our healthcare industry. But just having that day-to-day operational experience in multiple departments and touching a large, breadth of the organization, I think helped me propel me to success because I understood the challenges of our day-to-day staff. And I never wanted to lose that as a leader and, have that tight connection with them, say, hey, I walked in your shoes at one, for a number of years in my life. And so I understand what your day-to-day challenges are.
Yeah. And the one thing I remember about you is both when I got there and you were the interim supply chain leader and afterwards is you're always down to earth, face to face, always asking questions, wanting to learn more in a genuine way. And I think that probably has, really helped support the growth of your career. What I want to get into though, I wonder, I don't know if you've listened to any of these podcasts, but I've had a lot of big time supply chain leaders on from big time systems. But I don't think too many people understand the difference between a critical access hospital and a traditional not-for-profit IDN or an academic medical center or whatever. And we live in a time when many of these places are not only being merged and acquired, but are sort of disappearing. And I live in Northeast Ohio now, and we've had places like Massillon Community Hospital and other places that were once the bulwark of a community, where from the folks that live in that community have disappeared and become some name with Cleveland Clinic or University Hospitals on it that is completely foreign to what the folks in that community thought. Tell us about critical access hospitals, why they are operationally different, and as the president and board of trustees of the Illinois Critical Access Hospital Network, you're serving 14 million rural residents in your service area that otherwise might not have had healthcare access. Tell us about the importance of critical access hospital and how it operates financially differently from a regular not-for-profit hospital or system.
Yeah, a lot of aspects there. Let's start off with critical access and what does it mean to be a critical access hospital? So Medicare and Medicaid view critical access hospital as safety net institutions for our rural communities. And so as a result, we're reimbursed differently. We're reimbursed on cost. So, it's kind of like submitting your tax return at the end of the year. We submit a cost report to Medicare, Medicaid. Now, some states are good on Medicaid, others are not. But Medicare will pay you your cost. So essentially what that means is you're going to break even, right, on those two services. And that's 60% of our business. So really where it's important for critical access hospitals to be successful is to make sure that they do have commercial business coming in to their facilities. And that's a big focus for me when we took over the Alito operations. That's a small community. It's 16,000 in population. And we're right in the center of the county, and we see bleed off around the county because they're going elsewhere outside of the county. And they really need to use the local facility for us to continue to thrive and grow. And so we've been able to do that. Now, our story is different. Everybody's got a different story. We've been very successful. And I think I alluded to it earlier with Genesis mission and focus was we want to make that local institution as successful as we can, provide enough services there. So when we took over Aledo, we grew services. We added a lot of stuff to what they were delivering to the community so people could get that care locally, because they would have to travel 45 minutes. And a lot of, my colleagues, some of them, their patients have to travel twice that, 90 minutes away to get care. So that's why, it is so important for the fabric of our rural communities that you have that strong local healthcare institution. Not only can you provide that quality of care there, but also it typically is the number one or number two largest employer in the community. So the economic impact is so important. And unfortunately, and you brought it up, there have been a lot of critical access hospitals that have closed. And unfortunately, those communities, those rural communities, start a downward spiral. When they lose a major employer like that and that ability to, provide high quality care locally. So let's talk a little bit about, the critical access hospital network in Illinois. It's called ICANN for short. I've had the opportunity to work with that organization now for 7 years, was the chairman last year. But it represents every single critical access hospital as a member of that organization. And really, it's about collaborating and learning from each other. What best practices can we deploy in our individual entities to continue to remain successful for the communities that we serve? Now, a lot of Illinois critical access hospitals continue to be independent. So I would say a third are tied to a larger, system organization, but 2/3 are still independent. And unfortunately, after we got through COVID, when we saw, revenues increase and funding from the government help sustain operations, we've seen a number of closures since then. And I think you'll continue to see integration with larger systems. I can just speak about my own experience. For our organization, it has brought a level of expertise that had we not affiliated and brought in that larger facility, I know our Aledo operation would be closed today. So we brought, having the system resources of legal, HR, finance to bring a level of sophistication to our critical access hospitals, as long as they can understand the difference. And that's a learning curve as well. To me, that's key to success.
It's interesting because you were talking about Aledo being 16,000 people. Well, DeWitt's only 3,500, but DeWitt is almost like a suburb of the Quad Cities. So the DeWitt Hospital, while being important locally, did not have the same impact as the Aledo Hospital would have on its community as far as its relationship. Is that fair to say?
Yes, you're exactly right. It is kind of a suburb of the Iowa Quad Cities, but the population here has grown. To your point, it has kind of become a suburb. So we're up to 6,500
wow.
locally with the population, and then our service area, it's about the same as Aledo, but it's much more compact. We're about 10 miles around us. We have a number of smaller communities, so we care for about 14,000 people, and they use their local services.
Yep. The one thing I would say, though, that if I lived in DeWitt and there were no DeWitt Hospital, I just have to jump in the car and drive 17 miles to the Quad Cities, and I'd be at a high level of care versus many critical access hospitals in the country where there is no care around, where
Sure.
they are the only care, and that's why that's hence the word critical access. It's an appropriate name for what many of those folks in those places do. So what was it like for you to transition from a medium-sized IDN where you were the biggest fish in the pond to only having folks from Unity Health on the other side of the river to contend with, to all of a sudden becoming one of 101. 101 hospitals, I think my buddy Ed Hiscock tells me, is what Trinity is comprised of. What was that transition like for you folks?
It's very interesting. So March, so just less than a month away, will be 2 years since we've integrated into the Trinity Health System. Now, the way Trinity organizes their health system is by regional health ministries. So we actually came into Trinity under the Regional Health Ministry of Mercy One, which is based in Des Moines. So Mercy One is a large operator within Iowa and now Western Illinois with a couple of our Genesis entities. We're the number one provider of care in the state of Iowa, and we're the second largest regional health ministry within Trinity. So that's good. It gets us some attention. If we're not doing well, unwanted attention. But being the second largest part of that Trinity organization is important. The other thing is becoming part of Mercy One. They had 30 critical access hospitals. Not all of them owned. We only have 8 owned, but then we have 22 managed. Trinity had 2 critical access hospitals prior to the Mercy One Genesis organization joining them. So we've actually gotten some attention from Trinity and some support in that, because kudos to them, they recognize this is a different animal. Critical access is reimbursed differently, we bill differently, and our rural health clinics that are tied to our hospitals are also, different. And so we're starting to build that. It's been a little slower than I thought it would be. I thought after a year we would be more integrated than we are today. We're just starting to reach that integration now 2 years out, where now we just last 30 days, we changed all of our HR systems, all of our finance systems to be part of that Trinity Mercy One umbrella. So that's been painful, a lot of change there and, opportunities for new learning. But I think as we move into the future, we will continue that tighter integration. That was the one benefit that Genesis had as a small regional system. We were so tightly integrated. We had one system support, area for legal, finance, HR, all of those areas. Materials was another one. And they took care of all 5 hospitals. What we have found coming into Mercy One is that they're looking to what we have done within the Genesis organization to adopt those practices, because they were very disparate before.
Yeah, that was one thing I was always amazed with too, is when we introduced Lawson, for example, the way we integrated that system into our operation, it was, I thought it was just the way you're supposed to do it. And then after I left Genesis and returned to consulting later, I found out how many systems had absolutely blown it, and how well our folks had worked together through the process to make it work correctly. How has your role changed now that you're part of Trinity, if it's changed at all?
I would say operationally it has not changed much. There's more bureaucracy, as you would expect coming into a larger organization. So, where I had some independence to make some local decision making, whether, it be spending, different dollars to support causes locally, that has to go up a chain of command. But from an operational standpoint and the relationships locally, I still have that ability to have that freedom and to interact with my team in that manner. So, I think the support eventually will get to a place where it's really good and will help us succeed in our operations. But, it's still going to be a challenge and a path that we're going to have to go down.
But you're pretty comfortable with the way things are going, right?
Yeah, for the most part. Like I said, I hate bureaucracy, because I like the one benefit of being in a critical access hospital is you can move pretty quick. You have a small team. It's myself and our CNO. That is the leadership team, the 2 individuals, and then our management team under us, and we can make decisions and move quick. Can't move as quick as we used to, so it's just getting used to that and, having a good plan to take it forward and the rationale and, hey, here's what we need to do and where we need to grow.
Well, how do you work with Trinity's supply chain? Is it pretty much unchanged from what it used to be like at Genesis, or do you see any differences?
There's a lot of change in that has moved to national. So that is one thing that Trinity has done very well. Their supply chain is very, and I think you mentioned Ed Hiscock earlier. Um, Ed did a great job of integrating all of the entities across Trinity into that one service across the nation. And, I give him a lot of kudos in doing that. He was very transparent. He was very open. So, as Genesis was a new entity coming into this, our folks that ran our materials management departments knew exactly what the plan was. And they were much more integrated quicker within a year of Genesis entering that. So we've been able to take advantage of that, the national buying power that they deliver. And that was one of the reasons, one of the, couple reasons why we as Genesis wanted to join a larger institution. We wanted to take our cost of care down. We want to purchase things cheaper. The other thing was to lower our corporate overhead. Trinity does a great job of limiting their corporate overhead. And just to kind of give you some rough numbers, when we were Genesis, that tight 5-hospital system, our corporate overhead was about 28%. Last year, Trinity ran at 16%.
Yeah.
Multiple millions of dollars. And as we see our margins shrink and things get tighter, that was why Genesis joined a larger system.
Well, I tell you, if you have ever been, maybe you probably haven't, but in Livonia, Trinity used to have these 2 huge-ass buildings for supply chain, and they only have one now. And they have shrunk the operation to where it's leaner and far more productive than ever before. And, Ed, aside from also being my former boss, one time, we worked together for 3 years, is one of the best supply chain leaders in the country, bar none. He's a great thinker. And they, those folks have to survive. They're in that, let's face it, they're from Michigan, and there's a lot of disruption and dissonance there that they've had to survive just to still be there. So that's good. So what does the future look like for Ted Rogalski and Mercy One?
Well, the greatest thing and the thing that keeps me, thriving is the focus on growth and access. That's our key strategic items. And to me, I love it. When I got here to DeWitt, it's just been a couple years. We've been able to grow 3 of our services, our PTOT, cardiac pulmonary rehab, and our infusion services by over 30%. So it's just fun to be in that mode of growth and focused on, not shrinking, but growing the organization and really, increasing our access. So that's really our focus on our clinic operations. And the other thing that I did when I came to DeWitt, something that we did in Aledo a long time ago, is we had 2 individual physician practices that we brought in under the hospital umbrella as departments of the hospital and running them as rural health clinics. And that gets us access to 340B. So those are kind of the keys to our success, and we'll just continue to focus on that growth and, kind of fine-tuning that operation.
Ted, it's been great talking with you. And before we go, 2 things. Number 1, what did I forget to ask about that you'd like to talk about? And number 2, I understand you passed the golf clubs I've given you on to your wife. Is that true?
That is true. Yeah, she loved that driver.
Anything I missed that you'd like to add?
The only thing I would add is, hey, what do you do outside of work? And we've been blessed. We have 5 children. They've all married great spouses. So with the 10 of them, they've now blessed us with grandchildren. And our 7th one will be born here within the next couple weeks. It'll be our 2nd granddaughter out of the 7. And they range in age from 3.5 down to like 6 months. So we love bopping around and seeing all the grandkids and really enjoying that part of it.
Well, I've accused you on our last telephone conversation of taking your high school graduation picture and using it on the website for Mercy One. But you have you're still, to me, you're that young guy that I met back in 2000. Okay. And you're still looking great. You're doing a great job. And I am certain that your future is going to be great with Trinity organization. You're what they need. You've got a unique skill set about a type of organization that they really didn't have much experience in, and I think that'll stand you in good standing as you go along. So I think things are going to look good for you, Ted. And thanks so much for being on. Happy to have had you here.
It was good to see you, Fred, and happy to be with you this morning.
And that concludes this episode of Taking the Supply Chain Pulse. Subscribe and connect with us online to access other episodes you may have missed. If you'd like to be a guest on the show or have a topic you want us to explore, please reach out to Fred directly at fcrans@stonge.com, FCRANS@STONGE.com. This is Megan, thanking you for listening, and we'll see you next time.